Hi, good morning. We are here to finalize our journey. Today is 18th March, and I'm going to have very rapid uh, review or recap of our little issues with the camera. Yes, I'm trying to figure it out. Okay, okay, okay. So now esophageal carcinoma for ne- or nasopharyngeal carcinoma. Esophageal carcinoma or nasopharyngeal carcinoma. Okay. Immunohistochemical stains for esophageal carcinoma, also useful for nasopharyngeal carcinoma. Okay. How immunohistochemistry confirm carcinoma? How immunohistochemistry confirm carcinoma? How immunohistochemistry confirm carcinoma? How immunohistochemistry confirm carcinoma? Okay. How immunohistochemistry confirm carcinoma? This answer will be okay. How immunohistochemistry confirm carcinoma? Okay. Cytokeratin. Cytokeratin, this marker is typically expressed in squamous cell carcinoma, but not in adenocarcinoma. Cytokeratin. Cytokeratin is the marker. Cytokeratin is the marker. Is typically expressed in squamous cell carcinoma, but not in adenocarcinoma. Cytokeratin is the marker. Cytokeratin is the marker typically expressed on squamous cell carcinoma, but not in adenocarcinoma. And P63 and P40 commonly expressed in squamous cell carcinoma. P53, P63 and P40 commonly expressed in squamous cell carcinoma. Their specificity for squamous differentiation makes them useful in distinguishing squamous cell carcinoma from adenocarcinoma. Okay. Next is gastric cancer. These all are the new updates in the stations we need to go through. What is the plan post splenectomy? Is What is the plan for post-splenectomy? We have to describe about the vaccine and the antibiotic. Okay, there is an increased risk of thrombosis and susceptibility to infection with encapsulated organism. Okay, there is increased risk of thrombo. There is increased risk of thrombosis, as like other surgical procedures. After splenectomy, there is increased risk of thrombosis. There is increased risk of thrombosis and susceptible to infection with encapsulated organism. There is increased risk of thrombosis and susceptibility to infection with encapsulated organism. So, vaccine 2 weeks post-operatively, vaccine 2 weeks post-operatively for encapsulated organism like Haemophilus influenza, Neisseria meningitis, and prophylactic antibiotic against opportunistic overwhelming post-splenectomy infection. Overwhelming post-splenectomy infection. So, vaccine 2 weeks post-operatively for encapsulated organism like Neisseria meningitis, Haemophilus influenza, and pneumococcal (NHH), NHH, Staphylococcus, uh, Staphylococcus pneumoniae, or pneumococcus. So, Neisseria meningitis, Haemophilus influenza, and pneumococcal, and prophylactic antibiotic against overwhelming post-splenectomy, overwhelming post-splenectomy infection, overwhelming post-splenectomy infection, OPSI, overwhelming post-splenectomy infection, prophylactic overwhelming post-splenectomy infection, and influenza vaccine yearly. So, post-splenectomy, there is increased risk of thrombosis and susceptible to increased risk of thrombosis and susceptible to infection with encapsulated organism. So, post vaccine 2 weeks post operatively. So, vaccine 2 weeks post operatively for Haemophilus influenza and pneumococcal meningitis and Neisseria meningitis, and prophylactic antibiotic for overwhelming post splenectomy infection. That is for influenza influenza vaccine yearly. Nicely explained. Then, role of antibiotics. It is recommended that you take low dose antibiotics for at least 2 years. It is recommended it is recommended that you take low dose antibiotics for at least 2 years, and in many cases the rest of your life, to prevent bacterial infection. It is recommended that it is recommended to take low dose. It is recommended to take low dose antibiotic for at least 2 years, and in many cases, the rest of your life, to prevent bacterial infection. This is the role of antibiotic. It is recommended to take at a low dose of antibiotic at least 2 years, and in many cases, suppose those who are immunocompromised or is immunocompromised mainly, to take lifelong to prevent bacterial infection. Antibiotics are particularly important for children and young people under the age of 18, for the children and young people under the age of 18, and for the adults over the age of 50, for the young and children under the age of 18, and for the adult over the age of 50. And for the last 2 years, after your spleen is removed, for the last 2 years after your spleen is removed, for the last 2 years, after your spleen is removed, if your immune system does not work properly, if your immune system does not work properly. Okay, so this is the Antibiotics and particularly important for the children and the young people. For the children and young people under the age of 18, and for the adults over age of 50, for at least 2 years of after screenectomy. What is the age of screening for CDH1 gene? CDH1 gene age 16 to 18 years of age, and legal age of consent 16 to 18 years. Okay, this is the legal age of consent. Okay, what is the age of screening? What is the age of screening? What is the age of screening? It is 16 to 18 years of 16 to 18 years of age. 16 to 18 years of age. What is the age of prophylactic surgery between 20 and 30 years of age? What is the age of prophylactic surgery? Prophylactic surgery age is 20 to 30 years. Any prophylactic surgery, 20 to 30 years. Okay. And age of screening for CDH1, 16 to 18. Okay. Other malignancies of stomach other than adenocarcinoma. We have GIST, melanoma, GIST, GIST, beta cell lymphoma, GIST, beta cell lymphoma, neuroendocrine tumor like carcinoid, hereditary diffuse gastric carcinoma, HDC, that is uh, hereditary diffuse gastric carcinoma, and others, rare squamous cell carcinoma. Rare squamous cell carcinoma. Okay, in the stomach is rare squamous cell carcinoma. One is GIST, gastrointestinal stromal tumor, melanoma, and carcinoid. This is okay. And rarely squamous cell carcinoma. Okay. Mm, risk of liver biopsy for metastatic risk of liver biopsy for metastatic gastric carcinoma. Risk of liver biopsy for metastatic gastric cancer. Metastatic gastric cancer. Now we need to do liver biopsy. What is the risk? Risk of bleeding. Bleeding impairs due to impaired liver function. Risk of bleeding. Biopsy is risk of bleeding. Risk of bleeding because of impaired liver function. Bleeding in ascitic fluid and seeding. Bleeding in ascitic fluid and seeding. Uh, Risk of liver biopsy for metastatic ascitic cancer. Metastatic gastric cancer. Metastatic gastric cancer. If we do liver biopsy, what will happen? There is increased chance of bleeding because of impaired liver function, and bleeding in ascitic fluid. Bleeding in ascitic fluid also increase risk of seeding. What genetic abnormalities may be associated with uh, cancer stomach? What genetic abnormality may be associated with cancer stomach? One is CDH1 mutation, HNPCRC, APC, J, uh, TJ5, CDH1 mutation, CDH1 mutation, APC. How is chronic heart CDH1? What is CDH1 gene and function? CDH1 gene and its function. CDH1 is a E. cadherin gene is a tumor suppressor gene. CD8 gene is a tumor suppressor gene, includes a protein called okay, I don't think we need this one now. Type of mutation in CD8, type of mutation in CD8, type of mutation in CD8. One is autosomal dominant with LOF. This is autosomal dominant with LOAF of the tumor suppressor gene. Hereditary diffuse gastric carcinoma, hereditary diffuse gastric carcinoma, and autosomal dominant. Okay, so it is autosomal dominant, autosomal dominant, autosomal dominant, autosomal dominant. Type of mutation in CD8, it is autosomal dominant. Which patients you will screen for CD8? Family criteria: two or more cases of gastric cancer in family, regardless of age. Two or more cases of two or CD8. Okay, two or more cases of gastric cancer in family, regardless of age, with at least one diffuse gastric cancer. Two or more cases of gastric cancer in family, regardless of age, with at least one diffuse gastric cancer. One or more cause of diffuse gastric cancer at any time. Diffuse gastric cancer at any time, and more than one or more case of lobular breast cancer at age less than 70. One or more case of diffuse gastric cancer at any age. Okay. Okay. Family criteria, I would say first one. Okay. Two or more cases of gastric cancer in family regardless of any age, and mm, one or more case of lobular breast cancer in age less than 70 years in different family members. Okay, more than two or more case of lobular breast cancer in family members. Two or more case of lobular breast cancer in family members less than 50 years of age. Individual criteria: diffuse gastric cancer, age less than 50 years, diffuse gastric cancer at any age in individuals of every ethnicity, diffuse gastric cancer and individual with a personal or family history. Okay. What is the types of cancer associated with mutation in CD8 gene? Hereditary diffuse gastric carcinoma, hereditary diffuse gastric carcinoma, and gastric cancer, lobular breast, lobular breast cancer, prostate cancer, colorectal carcinoma. Causes of risk of gallstone and cholelithiasis following radical gastrectomy. Causes of causes of risk of gallstone. Causes of risk of gallstone and cholecystitis following radical gastrectomy. Loss of vagal innervation of the gallbladder. Loss of vagal innervation of the gallbladder. Damage of the hepatic branch of the anterior. Loss of hepatic. Loss of vagal innervation. Loss of vagal innervation of the gallbladder. Loss of vagal innervation. Loss of vagal innervation. Loss of vagal innervation of the gallbladder. Loss of vagal innervation of the gallbladder. Mm, Damage to the hepatic branch of the anterior vagus. Damage to the loss of vagal innervation of the gallbladder. Another mechanism is the loss of the cholecystokinin release from the duodenum after bypass of the duodenum. Loss of okay, loss of Loss of cholecystokinin release from the duodenum after bypass of the duodenum improves and Y reconstruction, and gallbladder contraction decrease and bile salt concentration increase. Gallbladder contraction decrease and bile salt concentration increase. Causes of post-gastrectomy acute pancreatitis. Direct acutogenic injury during gastrectomy, microcirculation compromise, duodenal hyper duodenal hyperpressure, and postoperative spasm of major papilla. Iatrogenic direct injury, iatrogenic direct injury, iatrogenic direct injury, iatrogenic direct injury of the iatrogenic direct injury of the pancreas during gastrectomy, and compromise, microcircular compromise, and duodenal hyperpressure and postoperative spasm for major papilla. Duodenal hyperpressure and postoperative spasm of major papilla. Causes of post-gastrectomy anemia due to vitamin B12 deficiency or iron deficiency. Causes of post-gastrectomy anemia. Post-gastrectomy anemia. Causes of post-gastrectomy anemia. Causes of post-gastrectomy anemia due to due to B12 deficiency or iron deficiency. Due to B12 deficiency. Due to B12 deficiency or iron deficiency. Due to B12 deficiency or due to B12 deficiency or iron deficiency. Due to B12 deficiency or iron deficiency. Causes of iron deficiency. Iron requires why iron deficiency? Okay, causes due to vitamin B12 deficiency or iron deficiency. Why iron deficiency? Iron requires acidic gastric media for absorption, which is lost. There is lack of absorption of the iron in post-gastrectomy reconstruction by passing the duodenum, such as the Roux and Y or Gilbert 2 approach, as iron gets absorbed in duodenum. Causes of post-gastrectomy metabolic bone disease. Osteoporosis and osteomalacia caused by reduced food intake. Osteoporosis and osteomalacia caused by reduced food intake and absorption, and steatorrhea. Steatorrhea interferes with absorption of calcium and vitamin D from the gut. Steatorrhea is caused by exocrine pancreatic insufficiency due to post-gastrectomy pancreatitis. Okay. Modified Duke's staging system. Modified Duke's 1 tumor into the mucosa of the bowel wall, but no further. Modified Duke B B1 B2 tumor penetrates into but not through the muscularis propria. Modified Duke's 1 tumor penetrates into the mucosa of the bowel wall up to the mucosa. Tumor penetrates up to the into the mucosa, not the bowel wall. Modified B B1 and B2. B1 tumor penetrates into but not through the muscularis propria muscle layer of the bowel wall. Okay, and B2 tumor penetrates into and through the muscularis propria of the bowel wall. So B1 tumors enter into the mucosa. Tumors enter into the mucosa. B1 tumors enter into the mucosa but not through the muscularis propria of the bowel wall. B2 tumor penetrates into and through the muscularis propria into the muscle wall. And modifies Duke C. C1 tumor penetrate into but not through the muscularis propria of the bowel wall. There is pathogenic evidence of colon cancer in the lymph nodes. Okay. C1, tumor penetrates into but not through the muscular sclerotia. Hmm. There is okay. Tumor penetrates into but not through the muscular sclerotia of the bowel wall, and there is pathogenic evidence of colon cancer in the lymph node. C2, tumor penetrates into and through the muscular sclerotia of the bowel wall. There is pathological evidence of colon cancer in the lymph node. C2, tumor penetrates and through the muscular sclerotia, and there is pathologic evidence of colon cancer in the lymph nodes. Modified modified Duke say the tumor which has spread beyond the confines of the lymph nodes to organs such as liver, lung, and bone. The tumor which has spread beyond the confines of other lymph nodes. Gist. What is the what is the risk feature of gist, including EUS? Okay, gastrointestinal stomach tumor, high high meiotic count, rupture, and rectal nodules should be excised. What is the risk features of gist, including EUS? Features should be excised even for asymptomatic. Okay, if it is ruptured, if it is high mitotic count, and rectal node should be excised. Okay, use of CD117 in GIST for diagnostic and treatment. Treatment adjuvant after surgical excision, adjuvant after surgical excision, neoadjuvant before surgical excision, and management of metastatic tumor. After treatment, patient develop CBD stone with fever, sepsis, abdominal pain, and jaundice. What are three predisposing factors for cholangitis and for gallstone? One is immunosuppression, drug use, and part of the abnormality. Immunosuppression: patient susceptible to infection, immunocompromised because he's been treated with steroid. If infection with cytomegalovirus can cause cholangitis, cholecystitis, and infection with Cryptosporidium flavium, sclerosing cholangitis. Drug used ascending cholangitis due to obstruction of the infection of the gallstones. Yes, ascending cholangitis due to obstruction and infection. Ascending cholangitis due to obstruction and infection by gallstone, and ERCP iatrogenic complicated by cholangitis and sepsis. That is the answer. No need this was complicated. These all answers I know. Okay. Lymphoproliferative disorder, WH classification includes four. Okay. What happens in hyperacute reaction in the graft? Immediate loss of graft occurs due to presence of preformed antibodies. What happens in hyperactive rejection in the graft? Immediate loss of graft. Immediate loss of graft occurs. Immediate loss of graft occurs. Immediate loss of graft occurs due to presence of immediate loss. Immediate loss of graft occurs due to presence of preformed antibodies. Due to presence of preformed antibodies. Type 2 hypersensitivity, which the type 2 hypersensitivity reaction. Okay. Antibody mediated B cell, cellular mediated T cell, CD4, CD8. Type 2 antibody mediated immunity and type 4 cellular mediated immunity. Types of rejection: hyperacute, acute, hyperacute, accelerated, acute, chronic. Hyperacute type 2 rejection, antibody mediated, inflammatory. Testicular tumor. Where food care is found in a normal meal. Two potential source of ACG and luteinizing hormone that act on sperm. Two potential two potential source of ACG, two potential source of HCG and luteinizing hormone. Two potential source of HCG. Okay. Two potential sources of the ACG. Two potential sources of ECG and luteinizing hormone that act on sperm. Two potential sources of 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 ECG and luteinizing hormone that act on sperm. Seminal plasma, female reproductive tract. ECG is detectable in seminal plasma. HCG is detectable in seminal plasma with also luteinizing hormone FSH, protease, seminal vesicles, and sebum. Even these are potential source for seminal plasma HCG. HCG produced also normally from female reproductive tract, ovaries, and uterus. HCG detectable in seminal plasma. HCG detectable in seminal plasma with also luteinizing hormone, follicular stimulating hormone. Okay, HCG is detectable in seminal plasma, luteinizing hormone and follicular stimulating So answer is prostate, seminal vesicle, prostate, seminal vesicle, even the testes are potential source of seminal alpha HCG. Prostate cancer. Why multiple biopsies in TQ RS? Prostatic cancer can be focal, so it is important. Prostatic cancer can be focal, so it is prostatic cancer can be focal, so it is important to take samples from prostatic cancer can be focal, so it is important to take samples from different sites. Prostatic cancer can be focal, so it is important. Prostatic cancer can be focal, so it is important. Prostate cancer can be focal, so it is important to take samples from different sites. So it is important to take samples from different sites. Um, Prognosis. Prostate cancer can be focal, so it is important to take samples from different sites. Prognosis: number of positive cores, percentages of malignancy in each score. To be able to calculate Lassen's score, most dominant, and second, prostate cancer can be focal. So it is important to take samples from different sites. And prognosis: the number of positive codes, and percentage of malignancy in each code. To be able to calculate Wilson's score. The most dominant and second common histological pattern. How to differentiate between rectum and prostate carcinoma in needle biopsy. In immunohistochemistry, carcinoembryonic antigen in rectal cell and PSA positive in prostate cancer. In prostate cancer, prostate antigen positive, and in immunohistochemistry, carcinoembryonic antigen in rectal cell will be positive. For immunohistochemistry, P63, high molecular weight cytokines should be negative and rectal tissue. No, no, the first question is not available. Malignant melanoma. What is the relation? It is a focal area of melanoma spread from the main tumor mass usually visible of the skin surface to the result of the melanoma. When considering additional cancer therapy, what gene mutation constitutes DROS gene? Genetic mutation is DROS gene. How would you treat this lady? Expression of the primary lesion with safety margin according to breast thickness plus go inguinal lymph node dissection plus radiotherapy. What are blood investigations in axillary vein thrombosis? Risk of pulmonary embolism. Arterial blood gases, B dimer. If one system B dimer, if B dimer is negative, likelihood of pulmonary embolism is low, very low. Not need to be if D dimer is raised, it should be done. differential diagnosis of breast diaphragm, infection, recent surgery, malignancy. Infection, recent surgery, and malignancy. Infection, recent surgery, malignancy. What are the stories of melanoma? Human classification of the melanoma. Melanoma stages according to AJCC institution. He is primary tumor thickness. Primary tumor thickness cannot be assessed. Primary tumor thickness cannot be assessed such as diagnosed by water test. T0, no evidence of primary tumor. Then T tumor, T0, melanoma in situ, stage 1. Very complicated way. MRCS stage is until melanoma. Excision of osteomyelitis and abscess. Bypass can sometimes be green. Pseudomonas aeruginosa produces green pigment called neutrophils release the green colored myeloperoxidase. Neutrophil release. Neutrophil release green co-ordered myeloperoxidase. Pseudomonas aeruginosa produces a green pigment. So one is neutrophil release some peroxidase from a neutrophil acidosis aeruginosa produced in the Y enlarged lymph in abscess. Going to give antibiotic. Rapid progression of the erythematous or abscess 3 or surrounding cellulitis, extensive abscess, multiple abscess, immunocompromised according to the scheme of age, prior clinical failure with the incision and drainage done, individual medication, individual medication devices such as prosthetic joints, vascular graft for pacemaker, or inspector for endocarditis, rationally to give antibiotics. Several recent trials have indicated the benefits of antibiotic therapy even a patient with small abscesses. Antibiotics decrease the likelihood of treatment failure. Antibiotics appear to improve outcome, decreases the risk of recent skin abscess, uh, adverse events. Um, Mild timing of antimicrobial administration. For most patients with surgeries withholding antimicrobial therapy until the sample for culture has been obtained to optimize culture result. For certain patients, we suggest that the antimicrobials be administered prior to incision and drainage. Patients whose incision and drainage cannot be performed promptly, patients with risk factors of endocarditis, other factors like systemic toxicity. Advertising targeted infection therapy that covers several focus areas, including MRSA, is appropriate. Trimethoprim two double-strength tablets twice daily, and doxycycline 100 mg orally twice daily. Doxycycline 100 mg orally. Doxycycline 100 mg orally twice daily. Generally, avoid clindamycin due to risk of Clostridium difficile infection and possibility of Streptococcal resistance. Mm, doxycycline 100 mg orally twice daily, and generally avoid clindamycin for the risk of developing Clostridium difficile infection and possibility of Streptococcal resistance. What are the preoperative intraoperative measures to prevent osteomyelitis after implants? Preoperative good preparation of the good preparation of the patient, good preparation of the patient diabetic control, preoperative weight loss for patient with obesity, smoking cessation, avoid long starvation, emergency sensitivity screening, and patient should be evaluated for the presence of activated, particularly uh, in the oral infection. This is intraoperative. Intraoperative. This is preoperative. Good preparation of the patient. Diabetic control. Weight loss for the patient with obesity, smoking cessation. Avoid long starvation hours. Avoid long starvation hours. MRSA and MRSA screening before surgery, and patient should be evaluated for the presence of activated particularly particularly intraoral infection. Okay, intraoperative strict antiseptic technique. Intraoperative strict antiseptic. Intraoperative strict intraoperative strict antiseptic strict aseptic technique. Skin preparation and prophylactic antibiotic. Use of antibiotic impregnated camera in prosthesis. Use of antibiotic impregnated cement. Use of antibiotic impregnated cement in prosthesis, and laminar flow. What is laminar flow? Continuous flow of highly filtered ultra clean air moving with uniform velocity in a single direction along parallel flow line. Continuous flow of highly filtered ultra clean air moving with uniform velocity in a single direction with a single direction along parallel flow line. The filtration of the air is through the highly okay. What is biofilm? What is biofilm? Biofilm is behavioral aggregates that are highly adherent to the uh, biomaterial surface prosthesis. Okay, they are okay. Biofilms are responsible for presence of implant infection, source of bacterial dissemination in the body. Okay. Leading syndrome. Collection of blood between the two layers of an artery, the tunica media and tunica adventitia. Bleeding through the tunica media, tunica intima, tunica media, and tunica adventitia. So bleeding pseudoaneurysm, collection of blood between the two layers of an artery, tunica media and tunica adventitia. 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 External wall consists of adventitia, perivascular tissue, blood clots, or layer of the tissue fibrosis. The blood within the pseudoaneurysm uh, recirculates into the kidney artery. Causes of bleeding tendency is rejection. Thrombocytopenia via immunomediated destruction of the platelet and metabolic cells. Severe also due to epithelial cell dysfunction and HIV-related liver disease. Uh, Decrease of hormonal factors production. Clinical symptoms of bone tumor and transfusion. Lymph fracture. Lymph fracture is a kidney shape surrounded by fibrous capsule with kidney shape. Lymph node. Lymph node kidney shape surrounded by lymph node kidney shape. Lymph node kidney shape surrounded by fibrous capsule, which extends inside a lymph node to form a trabeculae. A lymph node structure. Lymph node structure is kidney shape. Lymph node structure is kidney shape. Lymph node structure is kidney shape surrounded by lymph node structure is kidney shape surrounded by lymph node structure kidney shape surrounded by lymph node is kidney shape surrounded by fibrous capsule which extends inside the lymph node. Lymph node is kidney shape surrounded by fibrous capsule which extends inside a lymph node uh, to form trabeculae. Okay. It is kidney shaped surrounded by a kidney shape. Lymph node is kidney shape surrounded by a capsule. Kidney shape surrounded by a capsule which extends surrounded by a capsule which extends into the lymph nodes to form capillary. Outer cortex, it has outer cortex, it has outer cortex and inner medulla. It has outer cortex and inner medulla. It has outer cortex and inner medulla. Cortex underneath the capsule and the subcapsular sinus. Cortex underneath the capsule, cortex underneath the capsule, cortex underneath the capsule and the subcapsular sinus. Cortex underneath the capsule and the subcapsular sinus. Under cortex underneath cortex underneath the capsule and subcapsular sinus. Okay. It is kidney shaped surrounded by fibrous capsule. It is kidney shaped surrounded by fibrous capsule which extends into the lymph node and forms trabeculae. It has outer cortex and inner medulla. The cortex underneath the capsule and the okay. It has outer part on it. The medulla consists the medulla consists large blood vessel, sinuses, and medullary cords. Outer cord, outer cortex, inner medulla. The medulla contains blood vessel, sinuses, and medullary cords. A lymph node is divided into nodules. Each consists of a region of cortex, follicle, B cell, and paracortex T cell. A lymph node is divided into nodules. Each consists of a region of cortex called follicular B cell and T cell, and a part of nodule in the medulla. Show the nodule. Trabeculae, the mineral center, and polytrauma and transfusion. Why is formalin widely used for preserving tissue samples for fixing? polychroma and translation. Why is formalin widely used for preserving tissue sample or fixing? It links protein molecules together, increasing the visibility of samples. Formalin links proteins together. Formalin links protein molecules. Formalin links protein molecules together, increasing the visibility of the sample. Formalin links protein molecules together. Formalin links protein molecules together, increasing the visibility of the sample. Formalin links the protein molecules together and it increases the rigidity of the sample and making it easy to prepare thin slices for microscopic examination. Making it easy to make thin slices for microscopic examination. Formalin, formalin links the protein molecules together and makes the sample increase the rigidity of the sample. It links the protein molecules. It links the protein molecules together. It links the protein molecules together, and it increases the rigidity of the sample and making it easier to prepare thin slices for the microscopic examination, making it easier to prepare making it easier to prepare thin slices for microscopic examination. It also prevents DC and preserve the tissue as it also prevents leakage and preserve the tissue as long as possible. It preserves the tissue as long as possible. What are the contents of cryoprecipitate? What are the contents of cryoprecipitate? Contents of cryoprecipitate. What are the contents of cryoprecipitate? What are the contents of cryoprecipitate? Contents of cryoprecipitate. What are the contents of cryoprecipitate? Fibrinogen, fibrinogen, factor 8, factor 9, 1 Wilber factor. Yes. Fibrinogen, factor 8, 9, and 1 Wilber factor. And 1 Wilber factor 7. Okay. Fibrinogen, the contents of cryoprecipitate. What are the factors present in cryoprecipitate? We have factor 8, factor 9, 1 Wilber factor, and fibrinogen. Factor 8, factor 9, 1 Wilber factor, and fibrinogen, factor 8, factor 9, fibrinogen, factor 8, factor 9, fibrinogen, factor 8, factor 9, sorry, factor 8, factor 13. Fibrinogen, factor 8, factor 8, factor 13. Fibrinogen. Fibrinogen, factor 8, factor 13, and von Willebrand factor. Von Willebrand factor. Von Willebrand factor. Okay. Fibrinogen, factor 8, factor 13, and von Willebrand factor. So this is the carcinoma. Scenario: patient smoker with dysphagia, history of GERD, and loss of weight 20 pounds. What is the normal esophageal lining non-keratinized stratified squamous epithelium. What is the most probable diagnosis? Cancer esophagus. What the etiological factor of the cancer esophagus? This patient have chronic smoker, chronic GERD and smoker, and chronic smoker and GERD. What is the effect of prolonged GERD? Chronic GERD leads to development of the Barrett esophagus with increased risk of developing adenocarcinoma. Chronic GERD increase the leads to development of the Barrett esophagus, leads to development of the Barrett esophagus, leads to development of the Barrett esophagus, which increase the risk of developing adenocarcinoma. Which is to do for this patient? We do endoscopy with endoscopy plus esophageal ultrasound and FNSC. FNSC from okay. What the often cells will tell you: stage, grade, and immunohistochemistry. Stage, grade, and immunohistochemistry. Stage, grade, and immunohistochemistry. Stage. What the often cells will tell you. What the often cell will tell you. Often cell will tell you stage, grade, and immunohistochemistry. Stage, grade, and immunohistochemistry. What the often cell will tell you. Stage, grade, and immunohistochemistry. 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 What the often cell tell you. What the often cell will tell you. Often cell will tell stage, grade, and immunohistochemistry. Stage, grade, and immunohistochemistry. Stage, grade, and immunohistochemistry. Stage, grade, and immunohistochemistry. Often cell will tell stage, grade, and immunohistochemistry. Often cell will tell stage, grade, and immunohistochemistry. What is the stain used in immunohistochemistry? In immunohistochemistry, we use cytokeratin. Stain we use in immunohistochemistry, cytokeratin. In immunohistochemistry, we use cytokeratin. In immunohistochemistry, we use cytokeratin. In immunohistochemistry, in immunohistochemistry, in immunohistochemistry, what the often said will tell you stage and grade, and immunohistochemistry, stage, grade, and immunohistochemistry. What is the stain used in immunohistochemistry? Cytokeratin. What is the stain used? Cytokeratin. Cytokeratin. Okay. Pathology reports showed Barrett's esophagus, columnar metaplasia of the stratified squamous epithelium of the esophagus, type of lining, columnar epithelium type of cancer, adenocarcinoma, columnar adenocarcinoma, staging TNM, T2, T2N1, T2N1, muscularis propria. uh, into investment into the muscular protein. Treatment option for esophageal cancer. If operable, if operable, window-esophageal with window-esophageal with radiotherapy. Radiotherapy, hypolevis, if operable, esophageal radiotherapy, hypolevis esophageal or vacuum esophageal. If non-operable, debulking self-expanding metallic stent, palliative chemo and radiotherapy, feeding jejunostomy. If patient develop pleural effusion, what are the possible cause? Spread of the cancer. Okay. If operable esophageal, if operable esophageal, if operable will esophageal radiotherapy, hyperlevis and esophageal with hyperlevis esophageal or McCune esophageal. Hyperlevis esophageal or McCune esophageal. If non-operable will go debulking. If non-operable, if non-operable will do debulking self-expanding. Okay, if operable esophagectomy and with radiotherapy, esophagectomy either by Ivor Levis esophagectomy or McCune esophagectomy, radiotherapy, feeding jejunostomy. Yes, here also we keep feeding jejunostomy. And if non-operable, then we do debulking, palliative management, which includes debulking, self-expanding metallic stent, palliative chemo and radiotherapy, feeding jejunostomy. And if patient develops pleural effusion, what are the possible causes? Spread of the cancer to the pleura, lung metastasis, and obstruction of the thoracic duct. Obstruction of the spread of the cancer to the pleural, lung metastasis, obstruction of the thoracic duct. What pathological test to do effusion of the cytology? Effusion of the cytology. How to treat? We can do thoracocentesis. We can do thoracocentesis. We can do thoracocentesis. 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 We can do thoracocentesis. Indwelling pleural catheter. Thoracocentesis. Indwelling pleural catheter. Pleurodosis and pleuroperitoneal shunting. Thoracocentesis. Thoracocentesis. Indwelling pleural catheter. Pleurodosis. Pleuroperitoneal shunting. Okay. What is the pathological test to do? Diffusion test. How to treat thoracocentesis, thoracocentesis, pleuroperitoneal shunt, shunting. Pleuroperitoneal shunting, indwelling pleural catheter. Thoracocentesis, pleuroperitoneal shunting, and indwelling pleural catheter. Indwelling pleural catheter. Thoracentesis indwelling pleural catheter, pleuroperitoneal shunting, pleuroperitoneal shunting, indwelling pleural catheter, pleuroperitoneal shunting. Develop enlargement of the supraclavicular lymph node. What investigations to be done? What investigation to be done? We do um, what develop enlargement of the supraclavicular lymph node. What test or investigation to do FNSC? What test or investigation to do FNSC? FNSC. Okay, FNSC to do. Okay. Features under the features under the microscope. Metastatic adenocarcinoma with tumor cell. Metastatic adenocarcinoma. Features features under the microscope. Okay. Feature metastatic adenocarcinoma with the tumor cell having metastatic adenocarcinoma with the tumor cell having hyperchromatic hyperchromatic eccentric nuclei and intercytoplasmic uh, deglution. Features under the microscope. Metastatic adenocarcinoma with tumor cells having hyperchromatic eccentric nuclei. Okay. Features under the microscope. Metastatic adenocarcinoma with tumor cell. Metastatic adenocarcinoma with tumor cell having hyperchromatic nuclei and intercytoplasmic regulation Okay. Investigation for MI, ECG, troponin, CKMB. What is troponin? It is a complex of three regulatory protein: troponin C, troponin C, and troponin T. That is integral to the muscle contraction. Where it is found in the cardiac muscle and the myocardium and the skeletal muscle and the myocardium and the skeletal muscle. Immunohistochemistry was introduced in 1970s and has had a major impact on the histopathological diagnosis. The technique is the technique detects a specific antigen using an antibody. The antibodies are labeled with a dye, and to detect a specific antigen using an antibody, the antibodies are labeled with a dye, and when bound to its target antigen, is seen in the tissue section as a colored stain, often brown. Okay. Uses of immunohistochemistry, cell type. Uses of immunohistochemistry, cell type, neoplasia, differentiation, determination of site of origin, confirmation of neoplasia, selection of treatment, seeding of mutation, prognosis, cell type, neoplasia, differentiation, selection of treatment, screening of mutation and prognosis, microorganism, others, amyloid, immunoglobulin, and complement. What is immunohistochemistry? It is a method of localizing specific antigen in a tissue or cell based on antigen antibody recognition. It is a method of localizing specific antigen in a tissue based on antigen antibody recognition. How to do is the antibodies are usually the antibodies are usually linked. The antibodies are usually linked to an enzyme or fluorescent dye. When the antibodies bind to the when the when the antibodies bind to the antigen in the tissue, the enzymes or dye is the enzymes or dye is activated, and the antigen can be seen under the microscope. The antigen can be seen under the microscope. Okay. What is the type of enzyme antibodies recognition? Okay. So the antibodies are linked. The antibodies are usually linked with an enzyme or a fluorescent dye, and the antibodies are linked with the enzymes or a fluorescent dye. The antibodies are usually linked to an enzyme or a fluorescent dye, and when these antibodies bind to the specific antigen, in the tissue sample, the enzyme or dye is activated, and the antigen can be seen under the microscope. What is the type of antigen antibody reaction in chemistry? It is complement fixation. It is complement fixation. Complement fixation. Complement difference between immunohistochemistry and tumor marker. Immunohistochemistry is the work of the techniques used to examine samples for cancer tissue. The immunohistochemistry is one of the techniques used for examine sample of cancer tissue. Immunohistochemistry is one of the techniques used to examine the sample of the cancer tissue. This technique uh, uses antibodies to make certain proteins in the cell visible under microscope. Immunohistochemical. Immunohistochemical. Sorry, sorry. Okay. Immunohistochemistry is one of the techniques used to examine samples of cancer tissue. This technique uses antibodies to make certain proteins in the cell visible under microscope. Immunohistochemical tumor markers are proteins that help to differentiate between the different types of cancer. Tumor markers are proteins that are okay. Tumor markers tumor markers are protein that are produced by the body in response to cancer cell or by the cancer tissue itself. How immunohistochemistry helps in diagnosis of how immunohistochemistry helps in decision of chemotherapy. It helps in guiding treatment. It helps in guiding treatment. For example, in breast cancer, it will help determine the hormone receptor status. If negative, then the hormone treatment will not work, and the patient will require chemotherapy. How it helps in guide treatment. For example, in breast cancer, it will help to determine hormone receptors, and if it is the tumor is hormone sensitive, then we can treat the hormone. But if it is not hormone sensitive, the patient might need chemotherapy, and we will get this guidance by the immunohistochemistry. Acute pancreatitis. Acute pancreatitis. Okay. Acute pancreatitis station. Okay. What is amylase and what is the function? What is amylase? Amylase is a group of digestive protein found in the saliva and pancreatic juice. Mm, all are glycoside hydrolase and all are glycoside hydrolase and act on one four glycoside bond to convert amylase are group of digestive enzyme, and amylase is a group of digestive enzyme. They are found in the saliva and the pancreatic juice. They hydrolyzes starch. They convert starch into smaller carbohydrates. They convert starch into oligosaccharide and disaccharide. Um, okay, this in this way also you can say what is PCR and from where it is produced. This C-reactive protein, uh, C-reactive protein, it is a C-reactive protein. C-reactive protein is a substance produced by the liver. It is a C-reactive protein. It is a C-reactive protein. It, uh, C, CRP is a C-reactive protein which is produced in the liver in response to inflammation. Acute phase reactant. Acute phase reactant. It is not very specific. It is not unique to one disease. Can help to monitor disease progress and players. Can monitor disease progress and players. Okay. Again, C-reactive C-reactive is a C-reactive protein which is produced by the liver cell, especially hepatocyte, in response to acute inflammation. It is not specific to any disease, but it can guide us to monitor the disease response and the flare. What is the blood test to do in acute pancreatitis? Serum amylase, serum lipase, lactate dehydrogenase, CRP. Blood test, serum amylase, serum lipase. Preferred over amylase due to high sensitivity. Lactate dehydrogenase, CRP, and full blood count. Serum amylase, serum lipase. Serum amylase, serum lipase, serum amylase, serum lipase, serum amylase, serum lipase, lactate dehydrogenase, serum amylase, serum lipase, lactate dehydrogenase, CRP and full blood count, count. And biochemical test will do ECG, electrolyte, ABG, calcium, and albumin. Okay, so blood test will do CBC, full blood count, serum amylase, serum amylase lipase, lactate dehydrogenase, serum amylase lipase, lactate dehydrogenase, CRP, and full blood count. And biochemical test will do electrolyte, calcium, protein, electrolyte calcium, ABG, albumin, electrolyte calcium, ABG, electrolyte calcium, ABG, and albumin. The patient having a compression over the stomach. What is that? It is a cirrhosis. Compression over the cirrhosis. What non-bacterial organism can cause infection in acute pancreatitis? Non-bacterial cause like mumps, coxsackie, and hepatitis B. Mumps, coxsackie, and hepatitis B. Mumps, coxsackie, and hepatitis B. Parasite, right? Ascariasis lambricoides, fasciole hepatica, fasciole hepatica, and hereditary disease like bacteria, mycoplasma pneumoniae, and um, mycoplasma pneumoniae, and leptospirosis. Okay. Patient hemoglobin is dropped. Why? Rupture. Rupture splenic artery, rupture ischemic artery, um, gastrointestinal artery, pancreatitic artery, and severe aneurysm and hemorrhage. Rupture splenic artery, aneurysm and hemorrhage. What non-surgical options to stop bleeding? Intervention radiology by calling. Intervention radiology by calling. How does it work? Using a real-time image, the physician inserts the guide where using a real-time image, the physician guides a catheter through the artery and then release clotting agents, clots, particles and gels or foam into the blood vessel, showing the blood flow and causing an internal injury to activate the coagulation cascade. Okay, using a real-time image, the physician guides a catheter through the real-time through the artery and release the clotting agents. Um, the physician guides the catheter through the artery and release the clotting agents and release the clotting agent coils, particles, gels, or foam into the blood vessel, slowing the blood flow and causing an internal injury to activate the coagulation cascade. Which part of the coagulation will be activated? Intensive pathway will be activated. What factors involved in intensive pathway? Factor 9, 10, 11 factors 12, 11, 9, and 10. Whatever intensive pathway, okay. Venous ulcer in the forearm, not healed. Biopsy taken. Please, what are the criteria for malignancy? See, carotid tumor stations. What is the advantages of frozen section? Frozen section technique shortens the time to primarily diagnosis significant to tissue biopsy report. Frozen section shortens the time. Frozen section technique shortens the time to primary diagnosis significantly from traditional tissue biopsy and preparation. What other alternatives of frozen section? Fine needle aspiration cytology and FNSC and imprint cytology. Imprint cytology. Definition of combination of the proliferating fibroblast, loose connective tissue, new blood vessel, and scattered protein inflammatory cell forms a type of tissue that is unique to healing wound and called granulation tissue. Combination of proliferating fibroblast combination of proliferating fibroblast, loose connective tissue, combination of proliferating fibroblast, loose connective tissue, new blood vessel, and scattered chronic inflammatory cell, scattered chronic inflammatory cells forms a type of tissue that is unique to healing the wound and called granulation tissue. Fate of granulation tissue: remodeling the connective tissue that has been Remodeling the connective tissue that has been deposited by remodeling the connective tissue, that has been deposited by fibroblasts is recognized to produce the stable fibrous scar. Remodeling the connective tissue that has been deposited by fibroblast is a recognized to produce the stable fibrous scar. The procedure begins 2 to 3 weeks after injury. Bleeding ciliary aneurysm, okay, type for HIV, single stranded RNA retrovirus, single stranded RNA retrovirus. HIV1, HIV1 more common, HIV2 less common. Characteristic human immunodeficiency retrovirus transmitted through the body fluids. In most cases, HIV is sexually transmitted. Infection can occur by contact with a transfer of the blood, um, pre pre ejaculate semen and vaginal fluid. Non-sexual transmission can occur from an infected mother to her child during pregnancy, during childbirth. Okay, causes of true and false true aneurysm, congenital Marfan syndrome, Alzheimer's syndrome, acquired atherosclerosis, and severe true aneurysm types of congenital. Battery low. Please charge your speaker. True aneurysm. True aneurysm, aneurysm, Marfan's syndrome, Ehlers-Danlos syndrome, acquired atherosclerosis, infection, syphilis, false aneurysm, traumatic IV infection, horse rider and popliteal aneurysm, and surgery. Why does he have bleeding from the trauma? Liver battery low. Please charge your speaker. Liver involvement, hepatitis C, and hepatitis B virus affection. Okay, you keep pressure on water bleeding. Why not stopping? Because there is liver involvement and the affection of vitamin A dependent protein factor 2019 and precursor. Stop bleeding. When stop bleeding, okay. Apron, eye protection, double gloves, cap and mask, severely of clothing, injury of the blood vessel, platelets, aggregates, platelet plaque formation, activation of the intensive pathway. Why are clothing factors not working properly? Due to liver affection, where most of the factors are manufactured vitamin K protein factor 2009-10 and low CD4 count, damage to the bone marrow, where blood cells are produced. Very old. So we have finished this main stations. After that, we will start total anatomy whole unit.